Hello, everyone, and welcome to our session on sweating the small and big stuff, emotional health through the lifespan. My name is Ed Canda, and I'm a person with CF and a professor emeritus of social work. I'll be moderating the session this evening, and I'll be introducing our other speakers in just a moment. This session is also being recorded and will be available to all registrants after the event. This session reflects the wonderful work of clinicians and researchers who are supporting the CF community's strong priority on emotional and mental health and wellness. It's a coming together of insights from multidisciplinary research and perspectives of members of the CF community that address emotional and mental health challenges and ways to promote resilience throughout the lifespan. Before we begin with the session, I want to go over a few items related to the technology and how we can all interact. First, closed captioning is available and should be showing automatically on your screen. You can hide these subtitles or adjust the view by clicking the CC icon at the bottom of your screen. We will be taking audience questions during this session, so please submit your questions at any time into the Q&A box, and if possible, indicate the name of the person the question is for. We won't be able to answer questions about individual diagnoses or treatment plans, and we encourage you to use the information you learned today to have conversations with your care team. Otherwise, we will do our best to answer as many questions as possible verbally, and we will also be trying to answer questions by typing answers directly into the Q&A box, so check back there if we haven't answered your question verbally. You'll also notice the group chat for everyone who is in this session. Please note that you'll want to change the chat drop-down menu so that your messages go to all panelists and attendees. That way, everyone who is in the session can see your comments. If you have a question for the speakers, make sure you use the Q&A box to submit it, not the group chat. If you have any technology problems during the session, please return to the event homepage and click the live support chat icon in the bottom left of the webpage to connect with tech and program support. So our session is 75 minutes. We begin with reflections by Rachel Cravens, doctor of nursing practice and mother of Megan, a 23-year-old living with CF. Then psychiatrist Anna Georgiopoulos provides an overview of progress and challenges in CF mental health care. Then we move through the lifespan with presentations by pediatric pulmonologist Christopher Siracusa on birth through childhood, psychiatrist Anna Georgiopoulos on adolescence, and clinical psychologist CJ Bathgate on adulthood. Finally, I offer reflections from the standpoint of an adult with CF. Conclude with the question and answer period. We're so glad that all of you are joining with us to share in these insights about challenges and opportunities for emotional and mental wellness. Thank you to all the presenters. And now I turn this over to Rachel.
Thanks, Ed. Hi, my name is Rachel. My husband, Jerry, and I have 3 children. And as mentioned, our oldest daughter, Megan, has cystic fibrosis. Megan is doing well, and I'm excited to say that she is in her senior year of college, and she even just purchased her first home. However, things haven't always been as exciting for Megan. She had a very difficult childhood that consisted of many hospital stays. Sometimes it felt like we were in the hospital more than we were at home. Those hospital stays consisted of many surgeries, feeding tubes, IV lines, port placement, and G tubes. And I always felt like I knew what procedures were going to be stressful for her. I attempted to prepare her and always be honest with her. I wanted her to know exactly what to expect. I would explain to her what was going to happen, whether there would be pain, what to expect afterwards, and then always the reasoning behind it. However, relating information to her level wasn't always so easy. Just a quick story to display the difference in perspectives. When Megan had her G-tube placed, she was 4 years old. She was very scared, and the staff brought in this cute little doll that had a G-tube button. I thought, this is perfect. This is going to take away all of her fears and anxiety. However, Megan still wasn't too sure about it. She was very hesitant. But next door to us were these 2 boys that had cystic fibrosis. They were a little older than her, and they were often in the hospital at the same time we were. Sometimes they were in the hallway being seen having syringe water fights with the nurses. They were very well known to the staff. Somehow, one of the boys found out that Megan was going to have a G-tube placed, or he overheard the conversation or something. Anyway, he came to the door one day, proceeded to lift up his shirt, said, "Hey, Megan, it's no big deal." She giggled and giggled, and she said, "Look, Mom, look, Mommy, he has one." Suddenly, everything was going to be okay. None of the words or explanations that I had said to her meant anything to her. But because this young man had one and had showed it to her, everything was going to be okay in the eyes of this 4-year-old. So just to show a little bit of the different perspective that she had rather than what I had. So I often think of that young man, and I wish that I could go back and thank him. Oftentimes, emotions can be very overwhelming. And sometimes I showed too much of my anxiety and my fears in front of Megan. I regret that. I wish that I could take that back. It's 20 years later, 23 years later, and I'm still playing all those moments back in my head. As I mentioned, Megan just purchased a new home, and I've been packing up some of her stuff from her bedroom to send her way. She can store it instead of us, right? But anyway, I came across a notebook that she had that appeared to be a journal. I have to admit, I read through some of those pages. Don't worry, she's aware, I already confessed. But some of her entries made me giggle. She talked about her brother and sister. She talked about the dogs. And she even talked about how we went on a weekend trip and she had the entire backseat to herself. But then there were some entries that made me cry. And without going into a lot of detail about it, let me just say that some of the procedures and situations that I thought went really well and that we handled really well didn't go as well in her eyes. Even though she didn't always show it, there were moments of anxiety and fear that I didn't know about. There were procedures that I thought were no big deal that were a very big deal in her eyes. I wish that there had been more resources to measure her feelings, her thoughts. I actually wish there had been more resources for both of us. And as I hear about the new resources and tools that are being used, trialed, and brainstormed, it warms my heart to know that other families are going to have these resources and assistance. Fear and anxiety can have long-term effects on everyone: patients, parents, caregivers, friends, and even the nurses and staff. I'm very thankful for the clinicians and for all the research and all the resources that they are going to talk about tonight to share with you. So I would like to turn this over to Anna to hear more about the progress and challenges of mental health care.
Thanks so much, Rachel, for sharing your family story. I'm Anna Georgiopoulos. I'm consulting psychiatrist at the Adult and Pediatric Cystic Fibrosis programs at Massachusetts General Hospital in Boston. And I'm going to be speaking first tonight about progresses and challenges in CF mental health care. These are my disclosures. So first, let's start with the progress in CF mental health care, which has been really phenomenal over the past 10 years. First, there was the landmark TIDE study of over 6,000 individuals with CF ages 12 and above and 4,000 parents, which showed an elevated prevalence of depression and anxiety at 2 to 3 times the rate of that expected in the general population. At the same time, studies were accumulating, showing the impact on health outcomes and quality of life for people with CF. And as a result, the CF Foundation and European CF Society convened the first ever guidelines committee on CF mental health, focusing on screening, intervention, and prevention of depression and anxiety. In the US, the CF Foundation supported implementation of these guidelines with grant funding for 138 CF programs to start new CF mental health coordinator positions at their centers. And there to about 75% just 4 years later. So from a systems perspective, this initiative was really successful. But what was the perspective of people with CF and their caregivers about mental health screening? Well, the European CF Society Mental Health Working Group and CF Foundation Mental Health Advisory Committee sought to find out more about this and did a survey across Europe and the United States of 474 people with CF and their caregivers. And we asked a number of questions. I can only cover a couple of them tonight in the short time that we have, but you'll see at the bottom of the screen a link to the European CF Society Mental Health Working Group website. With 93% of respondents saying yes, 6% saying sometimes, and just 1% saying no. So it's clear that there are some positives here, but we also saw some hints of room for improvement. For example, we asked of people with cystic fibrosis who had completed screening measures in the CF clinic, did they have a conversation after completing the screeners? And 42% of the time, there had not been a conversation. So if there wasn't a conversation, did people wish there had been, or did they not want one, or was there So where do we go from here? Where are the gaps in CF mental health research? We know we still have a lot to learn, but what are the top priorities? So the CF Foundation conducted a mental health research prioritization survey in the summer of 2020 with over 1,000 members of the CF community and CF healthcare providers. So what you'll see on the left column here is a number of different possibilities for priorities in mental health research. And the responses of CF healthcare providers are in blue and the responses of CF community members in red. And what you can see is that the top 6 selections, there was very close agreement. These were really considered the top priorities by both groups: anxiety, depression, the effects of mental health on physical health, the effects of treatment burden, understanding risk factors and prevalence of mental health conditions, and the effects on families. However, CF healthcare providers were more likely to select certain topics, including substance misuse and disordered eating, as priorities. And on the other hand, members of the CF community were more likely to select other topics, such as side effects of CF medications, trauma, grief, and survivor's guilt. We'll be conducting additional analyses of these results and publishing those results to help stimulate research in CF mental health and inform the CF community of the top priorities. Finally, I'd like to share some mental health resources available on cff.org. There is multimedia content for the CF community and CF care teams on a variety of topics, available in both English and Spanish. And there are translations available or in process in other languages on the European CF Society Mental Health Working Group website. So I'm very excited to hear the rest of the presentations tonight. And with that, I'm going to turn it over to Chris to talk about mental health in childhood.
Thank you so much, Anna. I think we are having a little technical difficulties, and hopefully those will be resolved here soon. However, if I turn off my video, that is why. All right, so we're getting pulled up here. So again, my name's Dr. Chris Siracusa. I'm a pediatric pulmonologist and the CF Center Director at Cincinnati Children's Hospital. And like Anna said, I'm going to talk to you today about emotional health through the lifespan, specifically in birth through childhood, highlighting some of the issues as well as some research that is focusing on those issues. Here are my disclosures. So when does someone's CF journey begin? What we do know is oftentimes that begins with a phone call. And I would guess that many people on this phone call or on this webinar right now have received such a phone call. And we know that a new diagnosis of cystic fibrosis can impact the entire family and can cause a significant amount of stress starting at the time of diagnosis. And this is an event that is certainly a sentinel event in many people's journey. I actually had a patient literally last week who is 17, almost 18, and for some reason we brought up a sweat test and he didn't know what that was. And mom said, "Oh yeah, you had your sweat test, you know, May 3rd, 2002, or I made up that date." And he, you know, in a typical teenage boy fashion said, "Mom, how would you remember that?" And I jumped in. I said, "Your mom definitely remembered that day. That was a day that someone changed her life with a phone call." So 17 years later, in a family who has a very healthy teenager, that week, that day, that exact date is still quite memorable. So we know, as Rachel had mentioned, it's important to focus on not only our patients' mental health, but parents' mental health, and developing positive behaviors early on, because we know if we can develop positive behaviors and set people up for success, this will hopefully carry on as children grow up. We know that having those, health-related behaviors are important, but just overall wellness and taking care of yourselves and taking care of your children is a very helpful and important thing to start early on. But because, as Dr. Georgiopoulos just mentioned, high rates of anxiety and depression in parents for children, both with and without CF, as she mentioned in the TIDES data. And the European Cystic Fibrosis Society best practice guidelines encourages preventative counseling and emotional support for parents in the first year post-diagnosis. I'm not going to review the TIDES data again. However, there was actually a study that was just published this year out of Ohio State Nationwide Children's Hospital that was looking at admissions and how that was related to both health outcomes as well as other predictors such as caregiver mental health diagnoses, social barriers to care, and caregiver emotional issues such as fatigue and feeling upset in a more general term. And what we saw was that more so than the health diagnoses such as a NICU admission, a bowel surgery, et cetera, mental health diagnosis increase the odds of hospitalization more so than the other issues. Excuse me. It's a lot. Taking care of somebody with cystic fibrosis and ultimately yourself takes a lot, and sustaining daily care really there's a lot of factors involved in that. And those factors could be extrinsic, such as access to care, insurance, finances, transportation to clinic. These are often things that are out of our control, versus intrinsic factors that contribute to how people are able to keep up with their care. So understanding of their disease, literacy, which includes concepts such as organization, prioritization, being able to problem solve, as well as just motivation. And then a small word of time, which certainly means way more. It is quite clear that when you have a diagnosis of cystic fibrosis, you still get only 24 hours in a day. So being able to fit what your health recommendations are in addition to the rest of your life can be complicated, not to mention the medical effects. I put this quote here, I'm not going to read it, but this was a mother of a child with cystic fibrosis that really resonated, that how complicated and how much juggling does need to go on. And not adherence itself, which is a term that we use to say how often are people doing what they're recommended to do, but that is much more of a scientific word. And oftentimes what we hear from families is describing this sense or not a sense of burden. And burden, when we talk about that, is a very subjective feeling. It's how are we coping with this? And that is a combination of what is the schedule that's recommended, how complicated is it, what else is going on in life, what are negative coping mechanisms that we have, all of that increase our burden. And then factors such as positive coping and whatever help you get from your support and your community is helps lessen burden. And what we know is burden is something that patients and families talk about and acknowledge, and this is actually something that can be measured as well. So this is a study actually out of our organization that was just published this year, looking at assessing burden and complexity in a CF clinic in real time to guide interventions and conversations around treatment care plans. And what we've shown was that this can be measured in real time, and this is feasible, and this is acceptable to both patients and healthcare team members. If you're interested in learning more about this, there is a session on Saturday, the DCC workshop. Here's another example of some research that is focused on adherence, specifically in the preschool age group. We know that oftentimes the early years of life are focused around nutrition, and nutrition is not just calories in, absorption, and stool. It also often involves behavior. And a prescription from a doctor or dietitian that just says increase calories doesn't really go well in a 2-year-old or someone older. So over the last 2+ decades, Dr. Stark and her group have been studying using behavioral interventions to improve nutritional outcomes. I have permission to discuss it today. So over the last 2 years, we have studied a program called Be in Charge, which is again, tried and true behavioral intervention that we have now migrated into a mobile and web format where patients can track calories as well as communicate back and forth with their care team members using this app. And what we saw was a weight gain of 1.2 kilos, as well as increase in calorie intake of about 250 calories. And this was found to be both feasible and acceptable to families and clinicians, and look forward to these publications soon. We know that this is an issue, and anxiety and depression in children less than the age of 12 are not a group that is routinely or systematically screened in CF care, nor are the screens, the GAD-7 and PHQ-9, validated in this age group. However, we do know that there are certainly concerns. This is a study actually out of Turkey from a couple years ago that compared, that actually looked at psychiatric diagnoses in patients less than the age of 12, as well as over the age of 12, as well as looked at how those patients compared to each other and their disease severity. And what we found, or what they found, was, again, similar to that Ohio State paper that I published earlier, was that patients, either pre-adolescent or adolescent, with diagnoses of depression and pre-adolescents with diagnoses of depressions did have worsening disease outcomes and increased hospitalizations. But what does this look like in children? So depression can look like a lot of things in children less than 12. This could be irritability, restlessness, complaining of generalized aches and pains, not wanting to do fun things, difficulty in school, changes in sleeping and eating behaviors, as well as talking about things like death and dying. Whereas anxiety can present similarly with irritability and anger and inattention, but it can also present with feelings, overwhelming fear and worry that they can't explain. There's a few different types of anxiety. Specifically, to Rachel's point earlier, anxiety around procedures is a very common idea that is not only talked about, but is brought up by patients and care teams on a regular basis. I'm going to spend a couple minutes talking a little bit about procedural anxiety in a little bit. So when it comes to how do we treat anxiety and depression in children less than 12? Well, we know that there's evidence. There's not necessarily evidence in the cystic fibrosis community. However, there's a list of publications here for children less than the age of 12 managing depression and anxiety. And the CF Foundation and the European Cystic Fibrosis Society recommend evidence-based psychological interventions, including patients ages 7 to 11. There's been multiple interventional trials for adolescents and adults that Drs. Georgiopoulos and Bathgate will talk to you about. And these can possibly and hopefully be spread and implemented in younger children. But we know that in this age group specifically, family education involvement is crucial. So I mentioned procedural anxiety. So procedural anxiety is anxiety related to medical procedures, and this is experienced throughout the lifespan in different ways. And this changes over time, changes with development, and changes with experience. We know through a series of publications that negative pain experiences can have long-term consequences, including avoiding healthcare, as well as more chronic issues such as PTSD. And there's a lot that's involved here, but the key factors here are often the fear of the unknown. So what is about to happen to me with that scary person with a gown and gloves and masks and something in their hand? What were these past experiences that we have had? So last time someone came in here, it didn't go too well. I screamed for a long time and it hurt. And what else is going on in the environment? And there's lots of risks for negative experiences. So aside from what I just mentioned, the factors that are happening that day, did you get enough sleep? Did your child eat before coming to clinic? Are there any other underlying anxieties? As well as factors that are out of control of the patient, but are more team-based. So our healthcare systems are extremely complicated, and we are often rushed, unfortunately, and sometimes we don't do the best job that we can. What this means, though, is that there's lots of opportunity to build coping skills and provide support and practice these skills. So I'm going to mention two studies. One is a quite large study that is called the Comfort Promise study, and this is out of Wisconsin, and there's been multiple publications, and these Comfort Promises are included in the supplemental materials for this session. This was an impressive feat. This was a institution-wide culture change in which hospital leadership was convinced that this was important, that removing as much unneeded suffering and pain was a goal for this institution, this healthcare system. And what this group did over a period of years was really change the culture at every step of the way to, what is provided for patients at the time of the procedure, educating anybody who's performing something potentially uncomfortable, as well as again, getting institutional buy-in and support, and that really changed the face of how this hospital system was delivering healthcare, not just how they were doing procedures. It was quite an impressive feat. On a smaller scale, something a little more close to home for me, this was a study that we published a year or two ago that was looking at stress associated with pulmonary function testing. As many people with CF and families know, that PFT can be stressful, not just because of the test itself, but what it means. And there's a lot involved in why that could be stressful. Patients report they don't want to disappoint their care team. They don't want to come into the hospital. They feel fine. Sometimes they just don't believe such numbers. And what our respiratory therapists were actually noticing was patients were coming in quite stressed. So we did a quality improvement project where we were able to do stress measurements before and after PFTs. And for those patients that were interested, offered them stress-reducing interventions, such as listening to music, doing a mindfulness session, or just blind reading. Ed's going to talk to you a little bit about mindfulness later this evening. And what we learned was that for those patients that opted for this was helpful. It didn't add any extra time to clinic, and that they would like to do it again. So this, again, was a somewhat small study. However, we found lasting effects. And this was, again, something that any center could replicate and provide for their patients. So to summarize, and I'm sorry if my connection went out halfway through, stress associated with CF begins at time of diagnosis. Emotional behavioral concerns manifest differently as children age and gain experiences, whether those are good or not so good. And early behaviors predict future behaviors, same, whether those are good or not so good. Caregiver emotional wellness impacts child emotional wellness, and this should be addressed. Studies in CF are limited in this age group, though this does not mean that it is not at all an issue. We have evidence-based assessments and interventions, and there's a lot more to learn. What we will share and end with is that we're in this together. So with that, I'm going to turn this back over to Dr. Georgiopoulos.
Thanks so much, Chris. And so I'm going to speak about adolescence now, and to build on your theme, I'm going to talk about, my theme is going to be more to learn. I'm going to talk about several different areas that relate to research priorities, including resilience, ADHD, substance misuse, and modulators. So first, let me talk about resilience. This is a really important area in adolescence, and it's important that that adolescents learn skills in stress management. Abby Rosenberg and her colleagues are developing a study called the PRISM study to focus on 4 areas that are critical to stress management. One is managing stress, one is setting goals, the next is positive reframing, and finally making meaning. And these are conducted as a combination of one-on-one and family meetings with between session tools and practice. This intervention, the PRISM intervention, was developed for teens with cancer. However, it has been applied to the diabetes population and also now to teens with CF, with good data for feasibility and acceptability and a larger study in development. Next, I'm going to talk about ADHD in people with CF. ADHD is a neurobiological phenomenon marked by inattention, impulsivity, and hyperactivity. 16 to 22% of children and adolescents with CF meet criteria for ADHD in prospective studies using standardized diagnostic assessments. That's higher than the 8 to 10% found in retrospective naturalistic studies looking back at what was actually done clinically. And that indicates that we're probably missing, underdiagnosing and undertreating a lot of kids and adults with CF. For children with CF, the prospective rates are twice that expected in the general population. And for adults with CF, the rates are similar, 15 to 21%, which is actually 3 to 4 times more than expected in the general population. Parent, caregivers, and siblings may also be at risk. And for people with CF who do have ADHD, depression and anxiety commonly co-occur. So what do we know about the impact of ADHD and its treatment in people with CF? Well, so far, not so much. We'd like to know more about quality of life, sustaining daily care, and health outcomes. There are a couple of studies that give us some hints of what we might find out. In one pediatric CF clinic, poor executive functioning was associated with poor ability to sustain daily care and worse lung function. In our center, we showed that adults with CF who had elevated ADHD symptoms had lower quality of life on some domains of the CFQR. Next, I'd like to talk about substance misuse, which is the use of alcohol, illegal drugs, or over-the-counter or prescription medications in a way that they were not meant to be used. Over time, substance misuse can become an unhealthy way to respond to stress and anxiety, particularly when managing a chronic illness like cystic fibrosis. And I'd like to show a short video clip now about normalizing the substance misuse discussion.
I feel like what the CF community needs to know about substance misuse is how common it is. I think a lot of people, and it's not even just the CF community, has this notion that people living with a disability or a chronic illness, they live in these bubbles and they don't have the same desires as everybody else. They don't want to escape. They don't feel emotions or, whatever. And I think it's important to address that we're still human beings. We still struggle. And that's what's really hard is you're living with this chronic illness, but on top of that, you just have reality to deal with. And that's just 2 things that can equally be very, very difficult. So to try to deal with them at the same time, it is mentally and emotionally very exhausting. And I think that's why a lot of people do turn to substance misuse. And it's important to normalize the discussion.
Well, I'd really like to thank Sydney Sable for sharing her perspective on that important issue. And now I'd like to talk a little bit about what we know and don't know about substance misuse in people with CF. There is not sufficient evidence, but there is enough to know that people with CF do use substances and may experience negative health outcomes and lower medication adherence. Some of these studies are older and need to be updated, including some mixed findings regarding the prevalence of smoking and the need to include a study of e-cigarettes and vaping in future studies. We do have a more recent study of alcohol misuse in people with CF that indicates higher rates in people with CF than in the general population. In one anonymous survey of more than 900 adults with CF, 41% had excessive alcohol use, including binge drinking and heavy use, including people with CF in which use of alcohol could be more dangerous, including those with lung transplant or CF-related liver disease. In our center, we found that adults with CF who had a documented history of opiate misuse or alcohol misuse didn't have higher rates of diagnosis of depression and anxiety, but did have more severe symptoms of depression and anxiety, and also had more inpatient admissions and missed clinic appointments. So this indicates that depression and anxiety may be more challenging to treat when substance misuse is in the mix. And it's really important to address it. So I'm going to spend the rest of my time tonight on another important area that can become critical to people with CF, and in particular in adolescence, the effect of CFTR modulators on psychiatric symptoms. So some people have noted changes in mental health that coincide with starting modulators. I'm going to talk about what people have reported, how we understand these observations, and how we might manage these symptoms. First of all, it's important to understand that except for fatigue, neuropsychiatric symptoms are not in the top 15 adverse events in clinical trials of modulators. So the data that we have comes from case reports, case series, clinical experience, listservs, and blogs. And there have been a variety of changes noted after starting awCF, tezacaftor, and ivacaftor, or Trikafta, including for some people improved mood, but for others, depression, mania, or mood swings, increased anxiety, changes in energy, interest, or motivation, changes in sleep, including insomnia or vivid dreams, changes in thinking and concentration, such as brain fog, trouble with word finding, or memory difficulty, and changes in perception, such as hallucinations or intense sensory experiences. So how do we understand these observations? Well, one possibility is that it's a coincidence. We heard earlier about the TIDE study that depression and anxiety are very common. It's certainly been common for people with CF in recent years to be starting modulators. So we really don't have large scale epidemiologic data to indicate a connection. Another possibility is a psychological impact. Of course, improvements in health when someone starts a modulator are generally welcome. On the other hand, there can be complex meanings of taking highly effective modulators, including survivor guilt or feelings of uncertainty about the future, needing to have a change in future plans or frame of reference, or also the impact when a modulator might not be as effective as someone hopes it would be. I'm going to spend most of my time, though, talking about the other two hypotheses, a direct effect of modulators or drug-drug interactions. So this is a picture of CFTR found in the healthy human temporal lobe of the brain. And CFTR is actually found in many different parts of the brain. And so therefore, it's possible that there could be a direct effect via the mechanism of action of CFTR modulation in neural cells in our nervous system. However, it's also possible that there could be a drug-specific effect that's unrelated to the mechanism of action. And what that would imply is that one modulator might have an impact and another might not. So for example, we know that ivacaftor may have effects in the brain. It binds to neurotransmitter receptors such as serotonin, norepinephrine, and opioid receptors, and a dopamine transporter. And in mouse models of depression and anxiety, ivacaftor showed a benefit similar to the antidepressant fluoxetine. In one small human study, the combination of lumacaftor and ivacaftor improved anxiety on a health-related quality of life measure. We do know a little bit more about drug-drug interactions with CFTR modulators. For example, lumacaftor can decrease the levels of the antidepressants citalopram, escitalopram, and sertraline through one of the liver enzyme pathways through which drugs leave the body. This means that if someone were to start lumacaftor, for example, taking Orkambi, while they're taking one of these antidepressants, they could have a relapse of their symptoms because the levels would drop and they might need to increase their doses. On the other hand, ivacaftor could increase levels of some medications, such as escitalopram, through the P-glycoprotein pathway. That could lead to increased side effects of escitalopram and the need to reduce the dose of medications like that when someone starts ivacaftor, which is found in all of the modulators currently on the market. Now, although there's a little bit more clarity about some of these drug-drug interactions, This mechanism was not applicable in a case series of 5 adolescent girls who had new or worsening depression and suicidality, and in some cases increased anxiety after starting the combination of lumacaftor and ivacaftor in one CF center. So how might we manage these symptoms? We're proceeding in uncharted territory, so we need to consider individual experience and context. It's important if someone's experiencing something unusual to communicate the nature and impact of the symptoms. So is this like anything you've experienced before? How does the timing fit? Is it getting better or worse? How is it affecting you? To discuss potential interventions with your CF team. So what are the pros and cons? What are your preferences? What's someone's individual tolerance for known and unknown risks? Because people may make different decisions in the same situation. And above all, to use a systematic approach to considering interventions. And there are a variety of interventions that could be considered. So if someone were having mild or tolerable symptoms, it might be appropriate to not do anything different. If someone were having some trouble with adjustment, such as survivor guilt, a psychosocial intervention might be useful. Or a behavioral strategy, like for insomnia, that might be associated with starting a modulator. We could also use the usual psychopharmacologic treatments for symptoms we observe that would include dose changes for drug-drug interactions. Finally, we could adjust the modulator and note the response. So that might include an off-label dose change or temporarily discontinuing the modulator to see what happens. But of course, that would risk the loss of CF benefit. So it's clear that there's much more to learn about adolescent mental health and CF. I've talked tonight about a number of understudied topics that were identified as priorities in the CF Foundation Mental Health Research Prioritization Survey, including depression and anxiety, ADHD, substance misuse, and modulators. These are all issues that can emerge at the time of adolescence, a critical point in development with implications for managing adulthood going forward. And we have an opportunity for more research to better understand these concerns, their prevalence, risk factors, and impact in people with CF. And importantly, factors needed for building resilience, prevention, early recognition and intervention, and better treatments. So with that, I will turn it over to CJ.
Thank you, Anna. That was incredibly informative, especially about the modulators. I get a lot of questions about that in my center. And so let me go ahead and share my screen. And we'll get this presentation going. All right, so I'm going to focus on adulthood. What do we know and what are we doing right now? So I'm a licensed clinical psychologist and assistant professor of medicine at National Jewish Health, and I work primarily with adults. These are my disclosures. And let's just jump right in. So as mentioned earlier, elevated mood symptoms have been linked to poor health outcomes like decreased lung function, lower BMI, more exacerbations, increased healthcare costs, poor quality of life, and in a very recent study, increased mortality risk. So in a recent systematic review looking at psychosocial interventions in CF, the research team actually found no high quality published studies that address depression and anxiety as of the end of 2020. So clearly research has made the case that mental and physical health go hand in hand, and we need more evidence about what works. So as we move forward, I am going to focus on the most recent interventions addressing mental health in CF. And all of the studies I'm going to be presenting on are pilot studies. And so what a pilot study is it's a small sample size, and they're really used as proof of concept to support testing in a larger sample. So for each study, I'm going to be providing a brief breakdown of what the intervention is, who was in the sample, and how they did it. So in this study out of Drexel, researchers used 6 sessions of acceptance and commitment therapy, which really focused on increasing acceptance of one's physical and emotional experience and creating action plans based on one's core values. Now, this was a single site, one arm study, which is just a fancy way of saying all the participants were from Drexel and everybody got the intervention. What's important here is there's no control group though. So in general, having a control group is preferred because it can help isolate how much of a change is related to an intervention versus just getting better over time. However, control groups are not always possible in pilot studies due to small sample size. So 28 adults with CF were recruited, and they reported elevated depression and anxiety symptoms. They were typically female in their mid-30s with an average FEV1 FVC ratio of 69%. Now, some of you might be thinking, what the heck is that? So this ratio is not necessarily a standard measure of lung function typically used in research. Typically, we report on the FEV1 percent predicted. There we go. So I didn't have an actual baseline measurement of this, but it is a pretty close marker of FEV1. So mood-related measures were collected before and after the intervention, as well as at a 3-month follow-up. So the graph here represents effect size data, which measures the magnitude of change between either time points, such as before and after an intervention, or between group differences when an intervention has a control group, so intervention versus control. So the larger the effect size, the larger the magnitude of change. Okay, so for each graph, the blue bars are going to represent large effects, medium effects are going to be represented by the magenta bars, and then green is going to represent small effects. So the overall take home from this study is that ACT with CF improved anxiety and depression symptoms with a medium to large effect. So that's good. And it really just depended on the measure that was used. So for those of you that are on this, that are more familiar with different measures, I've included the abbreviation after the symptom on the right, so you can know how that was measured. So next steps for this group are to complete a randomized controlled trial, or an RCT, that compares ACT with CF to treatment as usual, and it's funded by the Boomer Esiason Foundation. The next study is CFCBT, which is an 8-session cognitive behavioral therapy study that focuses on teaching skills such as relaxation and reworking unhelpful thought patterns into more balanced, flexible thinking. So they also had a module that focused on taking care of your mental health during inpatient hospitalizations, which I think is really unique. So 14 adults with CF with mild mood symptoms were enrolled. They are typically females in their late 20s with an FEV1 around 67%. A unique aspect of this study also was that it wasn't just mental health clinicians that were delivering the intervention, but also other team members like nurses and pulmonologists. So data on mood, coping, and quality of life were gathered before and after the intervention, as well as during a 3-month follow-up. So again, using the same metric of effect sizes, remember bigger is better. The take home here is that CFCBT improved depression symptoms, coping, stress, and anxiety. And they also found improvements in health-related quality of life that I didn't include on this graph. So this group is actually currently wrapping up a big multi-site RCT with adults and is launching an adolescent version this month. So whenever you see the different icons of different institutions, if that's one of your institutions, think about perhaps if you might want to participate in this study. Now, related to the CFCBT program that I just spoke about is eHealth CFCBT. So lots of acronyms here. So this program took the tools from CFCBT, translated them into Dutch, and made it digital. So this pilot study really focused on getting feedback from adults with CF and healthcare providers on the acceptability and usability of a program like this. And what was particularly interesting about this is of the 8 sessions, 3 were completed with a therapist, whether it was telehealth or in person. And then the other 5 were really completed on their own, and they got email feedback from a therapist. So 16 adults with CF and 16 providers from different disciplines were enrolled in the study. In general, they were females in their late 30s, and the adults with CF had an average FEV1 of 72%. So this table here represents what adults with CF and healthcare providers thought about the intervention. So just by glancing at the numbers, there isn't a huge difference between the ratings. So let me just walk you through this. So the eHealth Impact Questionnaire and the System Usability Scale, which both use a 0 to 100 scale, suggests that people felt motivated and confident to change after they received the intervention and felt that it was really easy to use. Now, the lowest score on here was on identification, which rated how much they felt they had in common with the people represented in the intervention. And this resulted in researchers making changes to the intervention to better match what people wanted to see and their needs. So for instance, they added more male characters, there was less medical jargon, and more visual representation of key take-home points. So overall, people rated the intervention about an 8 out of 10, and this group now plans to test it out in the Netherlands with adults reporting mild to moderate symptoms, and they're going to test the usability of an English version of the program in an English-speaking population. Now, this next study is near and dear to my heart because it's one that I created and have piloted over the past few years called CALM. And that stands for Coping and Learning to Manage Stress with CF. So this intervention taught folks a blend of stress management and CBT skills, and it's been shown to be incredibly effective in other chronic health conditions. And what I did was I specifically tailored it to adults with CF and piloted it to see if it would work. So participants were randomized into either receiving 6 telehealth sessions of CALM or treatment as usual, where they did not receive the intervention, and we just measured what happened during the course of the study. So people were typically females in their early 30s with an average FEV1 of 66, and measures of mood, coping, and quality of life were gathered before and after, as well as during a 3-month follow-up. And I also got some data on feasibility and satisfaction. So since this study followed 2 different groups, right? Ones that got CALM and then the control group, the effect sizes here represent the magnitude of difference between the CALM group and the treatment as usual group after the intervention. Okay, so people receiving CALM reported improvements in coping and anxiety and depression with a medium to large effect size compared to those that did not get CALM. We also found between group improvements in quality of life, and I used feedback from the participants to further tailor the intervention. And so what's really awesome is 2 days ago, I just found out from the CF Foundation that I received an award to do a multi-site RCT, and that's going to be across this center, National Jewish Health, as well as the University of North Carolina and Johns Hopkins Medicine. So as we discuss different telehealth options, it goes without saying that COVID has changed the way that we practice medicine. So in this Italian study that was actually conducted during COVID, 16 persons with CF and 14 caregivers received 4 sessions of CBT skill building with a therapist. The persons with CF were typically females, and they were between the ages of 12 and 36, average FEV1 around 67, and the caregivers were, the range of age was 26 to 49. These researchers measured mood, stress, and feasibility, as well as satisfaction before and after the intervention. So the top half is going to show results for persons with CF, and then the bottom is going to show the results from the caregivers. So just by eyeballing this, you see that they follow the same pattern, and that the 4 sessions that were provided improved stress and depression with a medium to large effect size. And then there was a small effect for improvements in anxiety in persons with CF, but not for the caregivers. So what this group plans to do is to continue using telehealth as a means of care. And as I see it, telehealth is a modality that's here to stay even after we get over this pandemic. So the last intervention I want to share with you is an 8-session group telehealth intervention that focused on CBT and mindfulness. And I really want to emphasize group because this is the first one that isn't just focused on a one-on-one. This is gathering folks with CF together in a telehealth setting. So I don't actually have a demographic breakdown of the participants here, but similar to other studies, depression, anxiety, and subject feedback was gathered. So what you're going to see in this graph, so I was able to borrow some slides from an NACFC presentation, and it really represents just general pre-post changes in depression and anxiety that were measured using different kinds of anxiety and depression scales. So I didn't have the effect size data, but I did have this, so I wanted to share this. So the blue bars are average mood reports before the group, and then the red bars represent scores after the group. So in general, you can see that the group CBT intervention appears to decrease anxiety and depression symptoms. And then the amount of decrease was really dependent on the scale that was used to measure either depression or anxiety. So next steps for this group are to continue recruitment in their larger multi-site RCT. And some of those sites include Virginia Commonwealth, Cincinnati Children's, Johns Hopkins, Boston Children's, the University of Michigan, and the University of Buffalo. So just to wrap this up, as a member of the CF mental health community, I want to let you know that we see you. We see the challenges that CF can bring and just the sheer amount of resilience that you guys have shown during this pandemic. And I've highlighted multiple successful pilot studies that use different therapeutic techniques, and most are moving into the next phase of becoming a larger RCT. So if you are interested in emotional wellness, definitely reach out to your care center, see if there's any studies that you can get involved with, because we certainly cannot do this without you. So with that, I'd like to turn your attention back to Dr. Ed Canda to talk more about his experience as an adult with CF and facilitate any questions for the panel of speakers that you have heard from today.
Thanks very much, CJ. I'm glad to learn about these innovative studies, including yours. So hello again, everyone. I'd like to offer a few insights about surviving and thriving based on my perspective as a social work professor and as an adult living with CF. My career and personal life have focused on understanding how people can grow through adversity. My research has addressed refugees, health and mental health challenges, and disabilities. I've emphasized the ways people can grow by drawing on cultural and spiritual strengths to promote thriving. My personal experience highlights the importance of supporting emotional and mental health throughout my 66 years and onto the future. I grew up with the frustration of misdiagnosed and mistreated illnesses. I was shocked, yet relieved to have clarity at age 18 when I and my older brother received the CF diagnosis. I grieved at the loss of my brother 30 years ago. I faced many challenges managing CF symptoms as a longtime university student and professor, including many international travels. I have tremendous gratitude for my wife Hijaz's support and for care at CF centers. Now I'm retired in a new phase of life with new challenges for health insurance, plus unexpected and welcome health improvements due to Trikafta, all in the midst of a hopefully declining pandemic. Given all that, I'd like to share two insights that stand out for me about promoting wellness that I think are very consistent with the previous presentations. First, wellness is not just about individual effort. There's a crucial social context. We need to have proactive public health and social welfare policies and programs to promote a high quality of life for everyone. Services should be affordable, accessible, equitable, and holistic in order to support surviving and thriving, even with adversity. Secondly, at the individual level, mindfulness can be a great personal strength for coping and thriving. Therapeutic mindfulness practices can be helpful to reduce symptoms related to anxiety, depression, and distress, so they're now widely used in health, mental health, social work, and educational settings, including increasingly in CF care, as mentioned in previous presentations. So mindfulness is very important for me in daily life. Mindfulness cultivates awareness that is clear, gentle, and non-judgmentally present in each moment so that I can enjoy and live fully. It opens a space in my mind between an immediate experience and my reaction to it. This frees me for how to respond to pain and discomfort. I can be aware of it, but not trapped in it. Then I can respond with compassion and skillful care to myself and others. Even more significantly, mindfulness can become a way of life. Then every moment, whether stressful, joyful, or indifferent, becomes an opportunity for growing insights through the ups, downs, steady times, and doldrums of life. For example, Daily respiratory clearance and antibiotic inhalation treatments can be a real hassle, but they could also be opportunities for sense of gratitude and for self-care. When I view my medicine and the nebulizer, I view them with appreciation for all the people in the medical community and all other people and beings and the earth itself who made this possible. I receive them as a blessing. When I do my respiratory clearance and then inhale the nebulized antibiotic, I take this as a time to get centered and to pay caring attention to myself and to my breath in a meditative way, including if I'm coughing. But I want to be very real about this. Mindful living does not mean always feeling happy or having a positive attitude. Yet with mindfulness, even times of pain, worry, fatigue, or discouragement can be loosened, let go, and recovered from more easily. We can regard ourselves with acceptance, compassion, and care. Mindful living is about appreciation for the journey of life and experiencing growth and fulfillment along the way. With that final thought, I'll turn this over to Rachel.
Thank you, Ed. That was great. I'd like to thank you for presenting tonight, and I'd also like to thank all of our presenters. And now we can move on to the Q&A. Ed's going to tell us more about that.
All right, so now it's time for the Q&A session. As a reminder, please put your questions into the Q&A box and indicate who the question is for if you can. We'll answer as many questions as possible in the available time. So let's see, just a moment. I have a question that's maybe for Anna. Most of these studies have mainly females participating. Are females with CF more prone to depression and anxiety?
Thanks, Ed. That's a great question. Well, in general, women are more likely in the general population to be diagnosed with depression and anxiety than men. But it's an interesting question about why that might be. There could be hormonal factors or neurobiological factors, but it also may be that it's more acceptable in society for women to acknowledge if they're feeling down or vulnerable in some way. And an analogy would be, for example, in ADHD, boys are 3 to 4 times more likely to be diagnosed with ADHD than girls, perhaps because they're seen as more disruptive, whereas girls might be more inattentive. But that may not mean that that the rates are actually different of those phenomenon. It is interesting to note. I will give you a little sneak preview of some data from an abstract we submitted today for NACFC from the baseline data from the 60 people who enrolled in our CF-CBT trial of adults. We had 65% female. So that was much less female predominant than in our pilot study, but still female predominant. So I think we do have a ways to go to make sure that interventions for depression and anxiety and other mental health conditions are can be equitably delivered so that they are appealing to men and women, to people of different races and ethnicities, that we reduce the barriers to accessing interventions.
All right, great, thanks a lot. So now I have a question for Chris. How do you support depression in caregivers?
So I'm hoping that is for the universal you to supporting depression in caregivers. So this is a great question, and thanks for asking. And this is a topic that has been discussed and shared for many years at this point. And what is in the reality is there are some barriers to addressing depression and anxiety of caregivers in the specifically pediatric care model. There are legal issues, there are documentation issues, there are privacy issues that has made this a bit more complicated to roll out. However, what the CF Foundation has recommended that centers across the country have implemented is caregiver mental health screenings. So at least screening the information to understand the prevalence and how care teams are reacting to that information really does depend on a lot of those factors. So what are the rules in the institution? What are the rules in the state, et cetera? I can speak to, in general, those interventions can be anywhere from providing resources to actually providing therapy and everything in between. And again, a lot of variability across CF centers. In our institution specifically, we screen our caregivers at what we've decided upon intervals as well as needed. And depending on how high patients screen, how high caregivers screen, and if they want us to know that information, we provide them resources. We hook them up with community therapy and other interventions, as well as have the ability to respond to crisis. We've made ours, of course, optional, and not only optional to do the screen themselves, but to share that information with us. We encourage it. We encourage open and honest communication. However, we also realize that some caregivers don't want to talk about themselves in their child's CF clinic visit. So we do provide them with resources to take home and our number to contact. I hope that answers Janet's question.
Thanks, Chris. Here's a question for CJ. Any research or thoughts on survivor's guilt or medical PTSD?
So I will say I actually see this a lot in my clinical practice. And, as I'm learning more about medical PTSD, there's not a ton of data in CF. So there's a really great group out of the University of California, San Francisco. They just started doing these focus groups, one of which I was a part of, looking at medical traumatic stress. So there are people out there that want to know more about what this looks like in CF, because it might be different. Some of the things that came up were not just procedures like we might think. Some of it is just perception of scary experiences, hearing code calls when you're hospitalized, right? Because that might be, somebody on the floor, or just making you think about that in general. Kind of time lost from being in the hospital, and losing people when they have gotten a procedure that you might potentially get. So individuals that have lost someone close to them through lung transplant, and they know that they are approaching lung transplant. So that stuff is, we're definitely as a field looking at that and recognizing that it just might look different in CF.
Thanks, CJ. And I'd like to jump in with a personal thought about survivor's guilt. As I mentioned, my brother passed away 30 years ago. Here I am still going. And so when he died then, and over the years since, sometimes I had some feelings around survivor's guilt. But really what I came to was a sense of survivor's responsibility. I knew that my brother was happy that I was healthy, and if he knew that I was continuing this long, he would be happy about that. And he and I had many conversations over the years about death and dying and the meaning of life, and all of that was really good. So I carried that with me since. So that sense of survivor's responsibility, I don't mean that like a burden. I mean that as like a gift, and to appreciate the gift of life. And how do we share that? How do we pass that on to help others? Okay, so there's a question for Anna. Is there concern about using antidepressants in adults with CF?
That's a great question. And I'd be happy to answer if there's a specific kind of concern that I don't address. Please put a follow-up question in the chat if we have time, and I'm happy to address it. I guess what I will say is that the CF Foundation European CF Society guidelines suggested a protocol for intervention when people are screening positive for moderate to severe depression or anxiety. They have a clinical assessment that indicates, yes, this does seem to be depression or anxiety, and it does seem to warrant intervention, that psychological interventions, evidence-based interventions like cognitive behavioral therapy or interpersonal therapy are suggested as the first-line treatment, except in the case of severe depression, when it's suggested to start with both medication and psychotherapy, because the combination works faster and is more effective than one approach alone. That said, there are times when psychological intervention might not be something somebody wants. They might not have access to it. They might wish to start with medication, and that's typically fine. The medications that are recommended in the CF Foundation guidelines are selective serotonin reuptake inhibitors. And those were recommended because they have been around for many years. They've been well studied in people in the general population and people with medical illness in a variety of age groups. There are approvals in the United States down to the school age population for many of these medicines, and they're inexpensively available. There are a lot of different options, however. If someone starts with one of those medicines and finds that they have a side effect or it doesn't agree with them, there are a lot of other alternatives that they could use. There might be a few situations where some caution might need to be used. So if someone is taking a medication, for example, like linezolid, which has some activity that might increase the level of serotonin, we would have to consider that and watch somebody carefully if they were using a combination medicine like an SSRI, a serotonin reuptake inhibitor. Or there might be certain medications where if you have enough different medications that have a small side effect, it could lead to accumulation of things. And so that's true for any mix of CF medicines as well. So in general, antidepressants are safe and effective in children, adolescents, and adults, and should be used if they're helpful for someone and someone's interested in taking them.
All right, thank you. So here's another question. I think CJ would be interested in this and others may jump in. What do you think would be the top 3 mental health items to tackle in the coming years for CF patients?
So I think it'd be really cool if all of us answer this because we are focusing on different age groups. So for adults, just based on what I've seen in clinical practice, I guess this is in no particular order. Number 1 would be addressing just general stress from juggling more, right? We have these modulators, and I actually had somebody say today this great phrase that stuck with me. I feel like I'm the dog that caught the car. Like the challenge that they set out to do because they didn't think they had a ton of time, they did it, and now they're on this modulator and they're like, okay, so now what do I do? Like I've got more time, or I feel healthier. So how to kind of balance that. Another thing would be just fertility. There's been a huge baby boom with Trikafta. So a lot of people that thought they couldn't have families are now able to have families and maybe on an easier route than they thought before. And so what does that mean for people? And then the third is really, I think, around body image. We're seeing a lot of folks that have started with Trikafta that have gained weight and they just don't know what to do with it. And we hear this from both men and women. So I think that would be good to look at and help. Yeah. See what we can do.
Great. And actually we're unfortunately just about out of time. So I think that I need to wrap this up. So before we close, we want to draw your attention to some ways that you can be involved in upcoming projects about emotional and mental health and wellness. Community Voice comprises people from across the CF community to bring their unique insights and priorities to the forefront of research, care, and programs. When you join Community Voice, you receive tailored opportunities catered to your interests, from answering surveys to joining committees that you can do from the comfort of your own home when you have time. The only way to get involved in these projects is to join Community Voice, and you can join by visiting the web address here. There should be a slide coming up, or by texting the number on the screen. You can also find more information about Community Voice in the Community Resources tab on the event homepage. There are many wonderful resources related to all of the event sessions on the resource page. For this session, you'll find the slides we share and other items the speakers thought you might find valuable. Please spend some time exploring the resources and download anything that you want to keep. Thank you to all our speakers for sharing your knowledge and insights. And thanks to all of you for your attention and your questions.